Okay, we're going to finish this up now. Um, Looking at number, I think we finished on 22 or 23. Just for testosterone hormone replacement therapy, um, the goal there is going to be to get somebody to virilization with pretty high dose therapy, then sometimes decrease it down for the rest of their life. For purpose of goals for hypophysectomy with acromegaly, remember acromegaly occurs after puberty. So they have some of these changes that have occurred because of the acromegaly, the growth, and it can't be reversed. So having this done really kind of maybe stops some of the symptoms, but it doesn't necessarily change anything that already has overgrowth. Actions to take for nuchal rigidity. Make sure that you look up nuchal rigidity and just know that usually that's a symptom of um, some type of infection, and that your actions should really deal with how do you assess somebody for infection. Current interventions for low sodium with an SIADH patient. Um, with SIADH, the patients are going to be in a situation that you're trying to correct the low sodium, and obviously giving somebody low sodium, giving them a higher sodium diet wouldn't be a bad thing, but the most common and always the first line of treatment in these interventions is to put them on a very strict fluid restriction. You're going to see that on every patient, because you want that as long as that fluid problem continues, if you give them more sodium, it's still going to be lost. So the biggest thing is to really reduce the fluid. Safety interventions for skin for Cushing's disease. And I think this might be just a little bit off in terms of what the actual thought process was there. It really should just be safety interventions for Cushing disease patients, period. Just keep in mind or investigate a little bit further what Cushing's disease would do to the fragility of bones. And then think about how would you care for a patient that is in high risk, severe high risk osteoporosis. And that will help you a little bit with making those decisions for that question. Reason for tapering down slowly for doses of high dose corticosteroids. We do know that this does require weaning. If someone is taking off high dose corticosteroids, just one day they're on them, one day they stop them, or if they drop the dosage down too low from high quickly, they will have rebound inflammatory responses, and that is definitely not tolerated well. So, have to prevent that. With adrenal hyperfunction, these are patients that their adrenal glands are, you know, firing at a big rate with too much steroids, and because of that, patients are going to have emotional irritability. They might get irate easy. Just be aware that that is very common. It doesn't necessarily make them psychotic or anything like that, but they do really need to be, coached and educated that these feelings of this is normal, and just recognizing that as soon as we can get the adrenal hyperfunction back down to normal, that some of those kinds of reactions will subside. Chronic hypercortisolism and higher infection risk. I think we've said that again and again and again. Steroids high, immune system down. Making sure that they really have protection things in place, even at home in different settings that kind of make them less risk for infection. There are when someone is on prednisone, and particularly high dose, they have restrictions to not be in the sun as much. So you have to make sure that you really evaluate with the patient, what's their home life like? Are they the one that does all the lawn mowing? Do they have jobs that require them to be outside a lot? And then what precautions do they need to take regarding that? Emergency treatment of an acute adrenal crisis. When you have somebody in adrenal crisis, that means that they have severely, severely low steroids. And so, of course, the treatment of choice is going to be rapidly giving them IV corticosteroids. So, to do that, you really, first and foremost, have got to really quickly get an IV in a patient, and then you can initiate treatment. High glucose level with diabetes. Just think about your patient that would be in DKA. If their glucose is very high, plot out for yourself what would you expect the serum sodium to be, the serum creatinine, urine ketones, and serum osmolality, so that you would know what levels to expect there for that. Let's see. And perhaps with those, what levels for those would you probably have to initiate some treatment one way or the other. So for the next question that deals with number 33, that one, we've already beat to death in class, so I won't reiterate that, but the main way that you control that is with severe control of glucose. Risk factors, we went over those in class. You should be able to identify that. Please keep in mind that obesity and age make those factors even worse. I'll let you look up when would you use IM glucagon. Let's see, insulin pump usage guidelines. There's a certain time frame for changing needles that's recommended. Let's see. Clinical manifestations of DKA. I think we went over that in class, so that you could just make sure that you're able to pick those out easily. Now, for blood gases for DKA, remember that DKA is metabolic acidosis. So you want to recognize that metabolic acidosis and how that looks differently than respiratory acidosis on blood gases. The other thing to remember is when patients have Kussmaul's respirations, they are attempting to have respiratory compensation for the values that are going on with that acidosis. So that would mean that you might see some differences in, your CO2 in compensation by the respiratory system. So that's just your hint on how to really evaluate that. Actions to take with Kussmaul's respiration. Remember, Kussmaul's respiration is a symptom. We think, they're having a weird breathing pattern, need to throw oxygen on them. How do we correct Kussmaul's? It's a compensatory symptom. So the best way to correct Kussmaul's respirations is to give IV insulin and correct the blood sugar. And that will then, with all the other things like that's in the insulin protocol, gradually improve the acidosis, which is metabolic, not respiratory. 40 lab values most likely to require intervention. Just remember, we talked a lot about the things that we adjust, and you saw very easily that we're working on fluid balance. We're looking at adjusting the the blood sugar down without going too low, too quickly. We're trying to drop it 50 to 70. And we're also really being cautious about how that drops the potassium. So just be thinking about what's on that protocol in terms of values that you would really be watching for. Mental status changes in HHS. That is one of the most common goals of therapy, is to improve the mental status and cognition capability. These patients may be measured on a coma scale. So, if you're trying to really improve mental status with HHS and that's not occurring, then that would be a significant finding. Symptoms in anterior pituitary hyperfunction. You remember all the different hormones that are secreted by the anterior pituitary. So if those are all throwing down at once in hyperfunction and more excretion, think about what would you be seeing in terms of the patient examples of how they may have some of all the different symptoms of too much pituitary glands being released at one time. What goals of therapy would be if you were giving vasopressin DD AVP for diabetes? And this just really, look at, it's pretty easy. Think about diabetes insipidus. What are we having in terms of urine output? And what would our goals be in terms of concentrating the urine and decreasing and making the urine output more effective? So just kind of review that and make sure in terms of urine output, specific gravity, and osmolality, which direction are we trying to go with those with the treatment. Nursing interventions for ascites. If y'all haven't reviewed the audio tapes for hepatic and biliary, there are probably 7 questions at least that deal with some of those diseases. And you want to make sure that particularly these, but just listen to those real good as well. One of the key things that we do to decrease ascites in terms of nursing interventions is to put somebody on a low sodium diet and be very adherent to that. We also monitor INOs, but really the main goal is to kind of keep them on that type of diet so that it prevents this from getting worse. Most significant adverse effect of vasopressin, again, here we go with esophageal varices. Remember that esophageal varices are caused by, very enlarged vessels because of the backflow of blood. And so because of that, vasopressin, which is a vasoconstrictor, is used. But look up your side effects with that particular drug and know what you would be watching for in terms of really some significant problems. Okay. Probably some of you have even had patients that were on lactulose for liver issues, cirrhosis, and different things. But the whole goal of using lactulose is to bring the ammonia level down. And yes, it does cause diarrhea, but it's wanted diarrhea. We want that to occur because that, with the diarrhea, is pulling the ammonia out of the system. Highest risk factors for development of hepatitis B, I'll let you look those up in your book. Dietary teaching following laparoscopic cholecystectomy surgery. Remember what kind of diets that people really would need to be on following that surgery to prevent complications. Primary method to control discomfort in pancreatitis is really to keep them MPO and not allow them to eat. And then contributing factors for causing cholelithiasis. Usually those are listed on your slides, so be looking for those kind of things that make you more likely to get that. And just review all your medications for side effects and looking for any problems with anything.